So thank you. My name is Sharita Thomas. I am with the North Carolina Rural Health Research Program at the University of North Carolina in Chapel Hill under the Cecil G. Sheps Center for Health Services Research. I first want to thank the Academies for having me here with all of these wonderful speakers. I'm relatively new to this research, so I am appreciative for the opportunity. So this is kind of just what we're going to go over here. I'm going to take you through rural hospital closures, what they are, what we look at our research, what previous studies have shown. And in our research that I've done, looking at the rural hospital closure rate, a comparison among closed rural hospitals, and community characteristics involved in rural hospital closure. At the end, I want to take you kind of through a case study. It's a story of 2 hospital closures that I think kind of is very relevant to the discussion that we should be having here today. So, at the center that I work at, we track rural hospital closures. And so we define a closure as the cessation of inpatient care. A closed hospital can be considered as abandoned, where there are no health services that remain in the building where the hospital used to be. But that does not necessarily mean that there are no health services remaining in that community. Rural hospital closure can also be considered as converted. And that's when the hospital building where the hospital used to be, there's some other type of health service that's there. What we've seen, the majority of those different conversions being outpatient facilities, urgent care or emergency facilities, as well as nursing and rehabilitation centers. So, why then do hospitals close? So they close for a number of reasons. We can see that there are some hospital factors involved that causes a rural hospital to close. Those being, how many patients do you have in your facility at each day? Or management style, are they taking risk or are they keeping it safe? You can also, obviously there are some financial factors that go into rural hospital closures. How much charity care are they taking? How profitable is the institution? But along with those, there's also market factors that come into play. And so when we're talking about markets, my center, we kind of make hospital-specific markets where we look at Medicare reimbursement files and zip codes and kind of make a hospital-specific market based on percentages of admissions and discharges. And so with market characteristics, you want to kind of consider the competition. How close are they to the nearest facility? What is their insurance mix? What type of patients are coming in? How are they paying for their care? And so then when it comes down to these factors and you have a closure, what does it mean? What does it matter to have a closure? Well, for one, rural residents are already a vulnerable population. We know that they're older, they're poorer, they're sicker. They face more barriers to receiving care, that being health insurance if they have it or not, or transportation, which is the big one. So we have this vulnerable population, and then when you think about considering race and ethnicity, you're compounding that issue. Another reason why these closures might matter is a hospital doesn't just close because it's inefficient. It's not just about the financials. It's not a cut and dry free market. We know that there are differences in patient mix, reimbursement, ownership, for example, and these are just variables that we're able to measure. There are also some hidden variables, if you will, that we might not have considered. And there are some other forces at play there. So another reason why the closures would matter is because these closures are not regulated. So then how do we know that there is no longer a need for health services in the community where a hospital closure has taken place? So as of now, our center, we've tracked 121 closures since 2005. About half, so about 59% of these closures were abandoned closures, where there's no longer any health services remaining in the hospital building where the closure occurred. When you think about that, it makes you kind of wonder about the populations that might be impacted by these closures. If you just look at Alabama, for example, there were 6 closures that were experienced since 2005. Out of these 6, 4 were abandoned closures. And if we look at the market variables here, we can see that the abandoned closures had an average of about 24% non-white residents versus the converted, who had about 18%. None of these facilities had obstetrics care, and we usually see that that predates closure, the cessation or the removal of OB care. Closures is a problem in the South, as you can see here. Most rural hospitals, they are located in the South or the Midwest. But if you kind of look at this map here and you think about Medicaid expansion, if you want to overlay that over, where these closures occur, there's 10 out of the 19 states that have not expanded Medicaid. And you can see that concentration there. And if we think about the maps we've seen before, with the Black Belt and some of these Hispanic regions, or with the American Indian populations, you can kind of see that disparity there. Previous studies looking at other health facilities have shown that closures disproportionately burden racial and ethnic minorities. They also disproportionately burden those who receive Medicaid. So looking at some of the research that we did, our first study was a formative step here. We looked at the rate of hospital closures from 2010, and the previous research before on rural hospital closures dates back to the 80s. So what we've seen here is that, like, we compared the open rural hospitals to those that have closed, and so we saw that there were lower levels of profitability, there were smaller market shares, and the ones that had closed had served a smaller population. But remember, there are other factors that could influence closure that we probably did not consider here. Additionally, probably about half of those closures were abandoned closures. So what did our research leave out there? Like, as I mentioned before, we compared the closed to all open. That might not be the best comparison, as the financials might come into play. They're at a different playing field. Their markets are different. We did look at market characteristics in that, but we did not look at race and ethnicity. But the main thing that came out of this report was that we did identify a gap, that we need alternative methods of healthcare delivery for these rural areas. So to carry that research a step further, we looked at the same study population, but we only looked at closures. And so we distinguished between those rural hospitals that closed, that were abandoned, and those that converted to provide some other type of health service. We did consider race and ethnicity. We looked at competition, which was in miles to the nearest hospital. And we also got the community voice. So what we did was we surveyed members of the community. We sent out approximately 100 surveys. We got about a 34% response rate, and these were to city officials, members of the media, and healthcare professionals that lived in these communities where rural hospitals had closed. And we got the perception of the impact of these closures for the communities, and what we saw was that the community perceived that the vulnerable were those that were impacted the most. So that's the elderly, that's racial and ethnic minorities, that was the poor. They also mentioned the physically and developmentally disabled, that these were people that were most effective. They also saw, again, to mention transportation, already they were facing transportation barriers to receiving care, and now you have a hospital closure, and you might be traveling 30 minutes or more to the next facility. How do you make that happen? But again, we did leave out some things. What was our research missing here? We did see that the abandoned rural hospitals had a larger percentage of minorities or non-whites living in their markets. And most closures now, we know, are abandoned closures. There are no other type of health facilities in that building. So then how does race and ethnicity or SES play into the impact of closures? So the next study that we looked at, we took a more recent population of rural hospital closures, and we compared them to similar open rural hospitals that didn't close, and similar being those that were also at a high risk for closure but did not close. Closure in itself is still a relatively rare event, so when it comes down to it, it's thinking about what is it that pushes that hospital over to close, what is actually playing into that. We looked at the markets, and what we found was that those markets where rural hospitals closed, they again had a smaller market share, they had a higher rate of unemployment, and a higher percentage of Blacks and Hispanics. So what are these implications? What this shows here is that rural hospital closures may also disproportionately impact Blacks and Hispanics, like we've seen in other studies looking at urban areas or other types of health facilities. It also, again, highlights the need for alternative methods of healthcare delivery. And we heard before the comment about a shoe for everyone and the shoe fitting. Well, we need a shoe that fits for rural, but we also, in considering rural, we need a shoe that fits for those racial and ethnic minorities that live in these areas. It's not going to be a one shoe fits all. And so again, where our research had kind of left off is the main thing I think is how does race and social capital or political power play into rural hospital closures? And what about the health outcomes? What then happens to the communities when a hospital closes? And what are the other methods of healthcare delivery that we can look at? This kind of go to a case study here, 2 rural hospital closures in the state of North Carolina that kind of touch base with what we're discussing here. If you know some of your social justice, we have Reverend Barber here marching to DC with the Republican mayor from North Carolina as a story of one of the closures, and Golden Shovels over here for another closure. So let's take a look at this story here. We have 2 hospitals to compare. Both are in North Carolina. One is in eastern North Carolina, which is Pungo. It closed and abandoned. We have another rural hospital that was in western North Carolina, Blowing Rock, and it converted to provide nursing care. Both of these hospitals, though, what's interesting, they both closed, but they both had the similar rate or risk for closure, but Blowing Rock was able to convert to another health facility where Pungo on the west lost all services. So what's different about them? For one, we have population. Blowing Rock has a lot more people, but if you look at the composition of the people living in these areas, you can see that for Blowing Rock, majority white population, they have very little minorities, where in Pungo, still majority white population, but they have a lot more minorities. Taking it a step further, if we look at risk of need or socioeconomic factors, we looked at education, high school graduation rate, employment rate, income levels, violence. We also looked at health behaviors, the percent obese, the percent smoking, and we also looked at clinical measures like the percent uninsured and the number of health services or perceived quality of care. And we have that Pungo, as you can see from the areas in the middle, where they were a higher need area, and Blowing Rock is the larger triangle on the outside, that they were a lower need area. There was also the perception media coverage here. For Blowing Rock, it was pretty much a good story. The community was involved. They thought that the closure was very transparent. One of the headlines when it closed was that it was a great day for Blowing Rock. If you compare to Pungo, there was no transparency according to the community. They didn't know that their hospital was going to close, and when it did, they felt like the rug was pulled from under them. The leadership was seen as corrupt, and this led to the teaming up of Reverend Barber and Republican Mayor Adam O'Neill to march all the way to DC from North Carolina to discuss rural hospital closures. These are just some of our resources here, but I don't want to leave without stating we had heard some talk before, someone had mentioned accountability, and we need to hold ourselves accountable for where we are right now. We're in position of power, like with the research that we do, so we can do something. So we have to talk about race. We have to talk about history. We can't default to someone else to do this. Every one of us, if we're all engaged in public health, we're here. If we're watching, we have to look realistically at equity and bring the discussion back to race, racism, and history, because it's a social justice issue, and it's a discussion that we can't afford to miss out on. And when we think about health outcomes, we have to think about the causative factors there. What's the root leading to those health outcomes? When we talk about geography and health, there's a history there with those people. When we talk about the Black Belt, there's a history there attached to the health outcomes that you see. When you think about the American Indian population, as Ms. Livingston mentioned, there's a history there attached to those people that plays out into the health outcomes that you can't ignore. So I think that we don't want to forget that, and I will leave it there.